Hi everyone. I sure wish we could be face to face, but that's still not possible, so we'll need to learn all we can about GI disorders while Zooming together this morning. Today our focus will be on GERD, peptic ulcer disease, and cholecystitis, but much of the nursing care that we implement when caring for these patients is very similar to the care that we would provide for patients experiencing other types of GI disorders. Throughout the next 2 hours, I'll be covering the above 8 objectives. Again, what we will learn by understanding all these objectives will help us when caring for patients suffering from GERD, peptic ulcer disease, and cholecystitis, but when using our critical thinking skills, we'll be able to apply the knowledge that we learned today to many other health-related problems that affect the GI system. When I have the opportunity to talk with students and to learn with students, I typically don't just talk about specific health problems that you'll encounter when caring for patients. I believe that it's incredibly important to also discuss the art of caring, how we as professional nurses must treat our patients 100% of the time. How we care for and interact with our patients, no matter what they're dealing with, will make a huge difference in their ability to cope with the situation, and that will certainly impact their ability to recover. Patients admitted to the hospital with GI-related health problems often are in a great deal of pain. They have a difficult time finding comfortable positions, and they're often embarrassed because they have to discuss personal and private matters with basically strangers that they're not used to sharing with other people at all. We need to be understanding, kind, gentle, and definitely compassionate. How patients respond and handle their situation and their recovery period will depend very much on the art of caring. Listening to our patients, using therapeutic communication effectively, and focusing on how they feel are all important aspects of the art of caring. It's never just about addressing the actual health problem. It's always about caring for the whole patient, actually caring for each individual patient and their family and their significant others. If we do this, I think that you'll see your patients will begin to heal and recover easier, more comfortably, and the recovery will go quicker. So never ever forget the importance of the art of caring. Let's begin with a quick review of the GI system. The gastrointestinal system begins with the esophagus and ends with the anus. The digestive system includes all parts of the body that process food and expel waste from the mouth all the way to the end of your digestive tract, which is the anus. As you see in this diagram, the GI system consists of the mouth, the pharynx, the esophagus, the stomach, and the small and large intestine. So continuing with our review, digestion is the breakdown of food into smaller molecules. It gets the food ready for absorption. The digestive system helps the body absorb essential nutrients and is responsible for getting rid of all waste products. Digestion begins in the mouth where mechanical and chemical breakdown of food occurs. Peristaltic movement of the esophagus then moves the food into the stomach. The esophagus extends through the diaphragm and connects to the stomach, as you can see in the diagram. Here, digestion and absorption is now taking place. The gallbladder stores bile, which is a bitter yellowish green substance produced by the liver. When eating, the gallbladder releases bile into the intestine to break down food. The bile breaks down fat inside the intestine, which aids in digestion. Absorption is continuing and elimination will follow. So just review this slide and you can see all the different parts of the digestive tract, the GI system. And I like this slide because it briefly tells you what each organ does. So just review this. I think it'll help you as we go on to discuss the different health problems that we're going to talk about today. A digestive disease is any health problem that occurs in the digestive tract. The branch of medicine focused on the study and treatment of digestive system disorders is referred to as gastroenterology. Physicians practicing in this area are called gastroenterologists. By the end of our discussion today, you'll hopefully understand what GERD, peptic ulcer disease, and cholecystitis are, how these medical problems are diagnosed, and what the healthcare team and the patient must do to resolve, improve, or eliminate the problem. If you have any questions while I'm going through the slides, please just speak out. I don't always see hands raised because I'm so focused on the slide. So don't be afraid to just break in and ask a question, and I will I'll stop and try to answer it. And again, if you don't do that, certainly at the end of each problem that we're going to be talking about, I'll stop and ask if there are any questions before I continue. So GERD is the first problem that we're going to be talking about today. Gastroesophageal reflux disease obviously is what GERD stands for, but hardly ever do you hear anybody say gastroesophageal reflux disease. You're going to constantly hear people refer to this as GERD. It's a common chronic digestive disease, and again, it's the first health problem in the GI system that we're going to be discussing today. GERD is a chronic disorder. It occurs when liquid from the stomach backs up or regurgitates into the esophagus. The liquid may contain stomach acids and bile. This regurgitated stomach liquid can cause inflammation and irritation to the esophagus and refer to that as esophagitis. So in a nutshell, GERD occurs when the lower esophageal sphincter doesn't stay closed, it malfunctions, and when it does that, it causes a backwash of the stomach contents and acids back up into the esophagus, leading to significant irritation. The contents of the stomach can go all the way up to the mouth, causing the patient to have a really awful taste in their mouth, and that leads to a chronic cough. If the contents of the stomach irritates the larynx, the patient can suffer from laryngitis. So let me just say something about words that end in itis. So I don't know if you've taken a medical terminology course. If you haven't, it's a great course to take because it'll really help you understand all the medical terminology that we use in speaking and all the medical terminology that you're going to be reading about in journals and textbooks. But if you have an itis at the end of the word, it means that there's irritation. So if you have itis at the end of larynx, laryngitis, that means that there's inflammation to the larynx. If you have an itis at the end of the word esophagus, then the word is esophagitis. That means that there's irritation to the esophagus. So itis indicates inflammation or irritation. Okay, so again, just to make sure you understand why GERD is happening. It's happening because the lower esophageal sphincter is not staying closed, and this allows backwash of stomach contents and acids into the esophagus, leading to major irritation of the esophagus. So let's talk about I'm going to explain to you what could happen to the lower esophageal sphincter, what could happen to make it malfunction, but just to make sure we understand what happens when we swallow, right? So digestion starts in the mouth when food is chewed. Then we swallow it. The food, after we swallow it, is squeezed down into the esophagus, and the lower esophageal sphincter relaxes, letting food into the stomach. When that happens, or after that happens, it closes, and that prevents that contents that just went into the stomach from going back up into the esophagus. So we see that the esophagus and the lower esophageal sphincter plays a major role in GERD. So why can the lower esophageal sphincter not function properly? Well, it can be weak from pressure due to delayed gastric emptying, or it can close at irregular times because there's some kind of a mobility problem. So for whatever the reason, if that lower esophageal sphincter is not opening and closing properly, the patient can end up with GERD. There are important things to think about when you're caring for patients with GERD. First of all, think about how gravity works. So saliva coats the esophageal epithelium, helping to protect it from refluxed material. Refluxed material in the esophagus normally returns to the stomach with the help of gravity. And also peristalsis and saliva are involved also, but gravity plays a major role. When the esophagus is inflamed, the ability to clear reflux material is slower. This results in extended periods in which the esophagus is exposed to that caustic material that is from the stomach. Each episode of acid reflux results in increased blood flow, erosion or ulceration, and possible minor bleeding to the esophagus. Most reflux occurs during the day when we are upright. In the upper position, refluxed liquid is more likely to flow back down into the stomach due to gravity. Also, when we're awake, we repeatedly swallow with or without reflux. Each swallow carries any reflux liquid back to the stomach. So look at the picture on the slides. When you're lying down, there is no gravity. It's not at play here. The contents can flow back and forth in the esophagus. Just think of a straw, and the straw is lying flat down. If there was liquid in there, it would just kind of stay in there. But as soon as you turn that straw upright, the liquid's going to flow down to the hole at the end. So again, when we're standing up, gravity is at work, and the contents are able to go back into the stomach and not linger in the esophagus. So at night, during sleep, gravity has no effect, swallowing stops, and the secretion of the saliva is also reduced. Right? So reflux that occurs at night is more likely to result in acid remaining in the esophagus longer, causing greater damage to the esophagus. So we're going to take a closer look now at GERD by looking at a case study. I'm going to try to go through all three of these medical problems by giving you three different case studies. So our first case study involves Mr. Roberts. Mr. Roberts is a 25-year-old obese male. He's being seen in the outpatient GI clinic with the following complaints: heartburn occurring about 1 to 2 hours after eating, heartburn that worsens when he lies down and when wearing tight-fitting clothing. He's complaining of odonophagia, which is a medical term that means painful swallowing. And with that, you get kind of a sharp substernal pain when you swallow. He's complaining of pyrosis, which means a burning sensation in the throat. He's complaining of regurgitation. He's complaining of morning hoarseness or a sore throat. And he's complaining of a chronic cough. So we've talked about a lot of these things already and why they happen with GERD. If acid reflux gets past the upper esophageal sphincter, it can enter the throat or the pharynx and even the voice box, which we talked about, and that can cause laryngitis, right? So the hoarseness comes from that contents, that stomach contents, that acidy stomach contents irritating the larynx and making it difficult to talk. Mr. Roberts was very wise in seeking medical attention. The symptoms he's complaining of are significant, and they can lead to serious medical problems if they're not addressed. So seeking medical care was definitely the right decision for this patient. So let's look at the common manifestations of GERD. We've got pyrosis or heartburn, regurgitation or an acid taste in the mouth, dysphagia, which is difficulty in swallowing, odonophagia, which is painful swallowing. We can have hemorrhage. If there's hemorrhage and bleeding in the esophagus, then we're going to have a decrease in our H&H. The primary symptoms of GERD are heartburn, regurgitation, and an acid taste in the mouth. The heartburn typically described is something that feels like a burning pain in the middle of the chest, and it may extend, the patients say that it may extend up the neck and around to their back, and there may be sharp pressure like feelings. And when this happens, one of the first things that a healthcare provider would think about would be heart pain or angina. So typically we would work that patient up with at least an EKG just to rule out any heart problems. Typically, heartburn related to GERD is seen more commonly after a meal. GERD does not have to be present with heartburn, so you can have heartburn and not have GERD. So that's why, again, it's very important to be worked up by a physician. So I know I've also thrown out a lot of medical terms for you on these slides, so please make sure that you go over them and be really familiar with the medical terminology, because on exams we won't use things like patients having difficulty swallowing. We're going to use words like dysphagia. We're not going to say painful swallowing. We're going to use words like odonophagia. So just make sure that you are familiar with the medical terminology. So there are some additional manifestations of GERD, and they include aspiration pneumonia, chronic cough, morning hoarseness, and laryngitis. GERD can also result in ulcerations of the pharynx and the esophagus, and that can cause damage to the larynx, and we've talked about that already. And just to be clear, morning hoarseness is a result of the irritation to the larynx from the acid remaining in the esophagus for prolonged periods of time, because remember, at nighttime there is no gravity, so that those stomach contents are going to just be flowing back and forth, causing a whole bunch of irritation. So back to our case study. Mr. Roberts also has a history of smoking, drinking 1 to 2 beers a day along with other alcoholic beverages, eating red meat 3 to 4 times a week, and he likes eating spicy foods on a regular basis. So what this slide tells you is that a patient's history is extremely helpful in determining a diagnosis, and as we go on through this case study, you're going to realize why that is so. So risk factors and triggers that contribute to GERD are listed here: smoking, caffeine, alcohol, obesity, diabetes, fatty meals. And as you can see, Mr. Roberts has several risk factors of GERD. Alcohol can definitely contribute to making matters worse, because the alcohol can further relax the lower esophageal sphincter, plus it stimulates the stomach to produce more acid. So if that happens, there can be, a much greater risk of developing GERD. Remember that if the lower esophageal sphincter is not working, the food's going to flow back up into the esophagus. So what we don't want to do is make it more relaxed, which is why alcohol is really not a good idea to have if you have GERD. Based on Mr. Roberts' weight, risk factors, and complaints, the physician suspects that the underlying problem is GERD. So to confirm this, he does several different tests on the patient. One is a 12 to 36 hour ambulatory esophageal pH monitoring test, also a barium swallow with fluoroscopy, and an endoscopy. So the esophageal pH monitoring test is currently the gold standard procedure used for diagnosing GERD. This test evaluates the degree of acid reflux that exists. It's performed by using a tube with a pH electrode that's attached to the tip of the catheter. The catheter is placed in the nose and passed down to the distal end of the esophagus. The electrode is attached to a data monitor, and that monitor is worn almost as a little purse, has a shoulder strap, and the patient can just carry it around with them. Every instance of acid reflux and its duration and the pH level is recorded in the monitor. This instrument measures the gastric reflux over a 24-hour period. The patient keeps a diary of the symptoms and activities that he does over this 24-hour period. The test provides a direct measurement of acid in the esophagus. It's the most objective method to assess the severity of reflux disease and to monitor the response of the disease to medical or surgical treatment. Then there's the barium swallow. This is used to rule out structural problems in the esophagus. It can also evaluate damage to the esophageal mucosa. It's painless, but the one thing that the patient does have to do with this test is to swallow barium, which tastes pretty awful. So you need to be very patient with the patient and supportive, because no one really likes to drink that barium, but it's the barium that actually lights up what's going on inside the GI system. And the barium allows the doctors to take x-rays to see if there are any changes inside the esophagus. In terms of the upper endoscopy, this procedure looks at the upper digestive system. It's often performed as an outpatient procedure, as the other two can be outpatient also, and it's used to determine the cause of the heartburn. It uses a thin scope with the light and camera attached at the tip to look inside the upper digestive system. So it looks at the esophagus and the stomach and the duodenum, along with the first section of the small intestine. During this procedure, small tissues or biopsy can be taken, and this is important because it can rule out any possible cancerous lesion. So that is one important reason why you would do an upper endoscopy. So those are pretty much the three tests that you would do to help confirm a diagnosis of GERD. The test results come back, and the test results do confirm a diagnosis of GERD. So now it's time to think about a treatment plan. The nurses must explain the treatment plans to the patient. The patient has to be comfortable with the plan. The patients have the right to reject treatment plans, of course, if they feel uncomfortable with them. Or if the plan produces fear or confusion to them, they have the right to say, no, I don't want to do this. But oftentimes that confusion or all those questions can be resolved by either one, asking the doctor to come back and further explain in more detail the tests and the treatment plan, and also for us, the nursing staff, to sit down with the patient and answer questions and show pictures and just do whatever we can to try to help the patient truly understand how the tests are done and what they will confirm. So our job, along with the medical team, is to help the patient understand the positive aspects of the treatment plan, the impact that the treatment will have on their situation, and the fact that though the tests may be difficult, though these aren't too bad, or the treatment may be difficult, but again, the treatment with GERD is not that bad, but the fact is they're going to feel better after they begin their treatment. So usually that will help the patient be convinced that it's worth it. But always we need to be there with the patient and help with whatever their questions are. Remember, therapeutic communication is really important. And remember what we talked about at the beginning of the lecture about how the art of caring is really, really important. So the goals of treatment are listed here. Remember that GERD is a chronic disease. It may require long-term maintenance. Patients may choose to discontinue treatment because they either feel better or they simply get frustrated with the treatment and the procedures. Again, that is when the nurse needs to step in and explain and talk and be compassionate and understanding. The nurse doesn't judge whether the nurse will listen and help the patient to understand both the positive and the negative aspects of treatment. We need to be honest. Many patients who discontinue treatment will relapse within 1 year, and that is something that we can share with the patients also. Most patients will be dealing with medical problems such as GERD as an outpatient. Because of this, we can't underestimate the importance of discharge planning and patient education, along with connecting the patient with home health care nurses prior to discharge. We don't want a huge gap of time to occur between when the patient leaves the hospital and when they're seen by medical professionals, either their doctor or home health care nurses. Remember, it's important for the nurses also to understand the goals of the treatment, not just the patient. We can't help the patient understand what's going to happen or what we're going to be trying to do if we ourselves don't understand what the goals of the treatment are. So if you're ever in a situation where you're not sure you know what the goal is, sit down with the physicians and have them explain the type of treatment, the type of tests that they want to do. If you understand it, you'll be better able to help the patient. The goals of treatment can often be met by the medications that you see here on this slide. When you review this slide, pay attention to when the drug should be taken. Many of the drugs stand out for some specific and important reasons, so you want to make sure that you look at the drugs individually and kind of know what each specific drug does, how long they act. Are they short acting? Are they long acting? What some of the risks may be. But those are some of the important things to study when you're looking at these medications. Antacids, it's important to know, are intended as a temporary relief only. Further testing or alternative treatment should be considered if a patient has to continue using antacids. So you don't want to just use antacids over and over and over again and not really get any real relief, just short-term relief. Then something's going on that these antacids can't fix. So it's important for patients to know that if they take antacids and they don't get a lot of relief, and it's not long-term relief, that they really need to see a doctor. Cimetidine is a short-acting drug that is a really good drug, but when used with certain other medications, it can interfere with them, especially when they're used over a long period of time. So that's something to know about cimetidine. Cimetidine works well at decreasing gastric acid production, so it's a good drug to be able to take if that's the problem. But again, if you're taking other drugs, the cimetidine can interfere with how those other drugs are acting. It's important to know one thing about prokinetics, and that is that they're linked to fatal heart arrhythmias. So prokinetic meds stimulate contractions of the stomach muscles. They're used to treat dyspepsia, but primarily they're used to prevent GERD. What they do is boost the strength and frequency of muscle contraction, which helps the stomach to empty faster, which will then reduce the reflux of the stomach acid. So what prokinetics do is great, but the side effect is really pretty significant. Cisapride is one of the drugs in this category, and it's very well known to have, as a side effect, fatal heart arrhythmias. So with this drug, it's only available to patients who meet certain criteria that's been established by the drug's manufacturer. A physician must enroll a patient in a special program before the medicine is provided. And again, not only is it used because it helps the stomach to empty faster, but it's also used to treat symptoms of nighttime heartburn in patients that haven't responded well to other treatments. Researchers are constantly looking for other ways to improve prokinetics so that they can eliminate the fatal heart arrhythmia side effect, which is obviously very significant. What else do I want to tell you? Patients may be tempted to stop their medications because of how it's making them feel or because they have to take it over a prolonged period of time. So it's important for us to explain to our patients that they should always talk to their doctor before stopping any of their current medications. Their doctor may be able to substitute other meds if it's not safe to completely stop the specific medication that's causing the patient some problems. Remember that giving the medication to patients is really the easy part of medication administration. It's understanding all the aspects of the patient's meds that is especially challenging and incredibly important. So I think the best thing to do with this slide is for you to review it and really try to understand, like I said, what all the different drugs do and what their side effects are and when you should take them. So review this slide, and also it would probably be a good idea to review the table on page 1284 in your textbook, table 5-2. It's on page 1284 in your textbook. A small number of patients with GERD do require surgery. Candidates for surgery are patients who have not responded well to medical treatment or have developed complications. The gold standard surgical procedure is the laparoscopic Nissen fundoplication. We know with GERD that the lower esophageal sphincter is not working effectively. So this procedure is essentially creating a one-way valve to compensate for the defective lower esophageal sphincter. Foods and juices can go down after this procedure, but nothing can go up. There's no regurgitation. So basically what this is that with the laparoscopic Nissen fundoplication, the gastric fundus, the upper part of the stomach, as you can see here on the diagram, is wrapped around the entire lower end of the esophagus and stitched in place. This reinforces the closing function of the lower esophageal sphincter and actually then is creating a one-way valve. Vomiting is sometimes very painful or even impossible after a fundoplication, with the likelihood of this complication typically decreasing in the months following the procedure. When trying to simply reduce gastric reflux, difficulty in vomiting may be an undesired outcome. In extreme cases such as alcohol poisoning or food poisoning, patients may be able to vomit freely but with a certain degree of pain. Again, initially the vomiting may be impossible. However, over time the sutures may loosen a little bit and small amounts of vomit may be produced after the wrap has had time to settle. But again, most patients when they're treated medically, not surgically, but with medication, do very well. Let's turn our attention now to some of the nursing interventions that are important to include when we're caring for Mr. Roberts. A lot of these nursing interventions are part of the education that we're going to be doing with Mr. Roberts. First of all, we need to explain to Mr. Roberts and all GERD patients that GERD is a chronic disease requiring long-term maintenance. So oftentimes patients get discouraged and get tired of taking their medication and they want to stop it. And we just have to make sure that they understand, one, to see their doctor before they would do that, and also to explain to them that patients who discontinue their treatment, like I said before, will often relapse within 1 year. The other thing that we need to make sure we talk to our patients about is the whole thing of taking antacids. If individuals find themselves taking antacids throughout the day without substantial relief, they must be encouraged to see their doctor. Antacid use should be discussed with their doctor, who will explain safe daily dosing that's needed to neutralize gastric juices and to prevent esophageal irritation. Remember that excessive use of antacids can cause rebound activity, and that causes increased discomfort. So again, talking about antacids and the proper use of them is really important. Remember that the health care outcomes in patients with GERD are primarily a result of lifestyle choices. So we have to remember that these changes don't happen overnight. So again, we have to be patient, provide support and understanding, and we can't be judgmental. So review this slide. Be familiar with the nursing interventions as well as their rationales. It's really important to understand the rationales to each of the interventions. If we go into our patients and just begin doing things because we know that that's a good thing to do if a patient has a specific disease, but we don't understand why we're doing it, then I don't know how anybody can accurately assess their patients. You won't know what to look for. So it's just really important, especially when you're teaching your patients, to truly understand the rationales behind all the different interventions. And the interventions that I put up here are just some. There are many, many more. But again, very important to make your patient understand that drinking alcohol should be eliminated. Remember that both smoking and alcohol can cause a decrease in the lower esophageal sphincter pressure. It can make the LES more relaxed, and that can increase the risk of reflux. Avoiding the tight-fitting clothing is important. Well, why is that important? It's important because tight-fitting clothing can cause an increase in intra-abdominal pressure, which weakens the LES, resulting in reflux. It's the same reason why you shouldn't bend over. If you bend over at your waist, especially after you eat, you're going to increase intra-abdominal pressure. Remember that encouraging small, frequent meals is a really good thing to do. Eating larger meals will cause a delay in gastric emptying, which can lead to reflux. So just go over all of these different interventions, know and understand the rationales. And if you're not sure of something, either email me and talk to me about it so I can explain it to you, or look it up in your textbook. But again, one of the most important things is that a lot of this, of course, is just changing your lifestyle. It doesn't happen overnight, and as a healthcare professional, we need to be supportive and non-judgmental. One more important fact to share with Mr. Roberts is how Mr. Roberts should sleep. This diagram demonstrates the reasoning behind sleeping on the left side, and that's what we want to teach patients with GERD, that it's a whole lot better to sleep on the left side. So if you look at this diagram, you can see why. Look at the right side, look at the left side. When lying on your left side, the esophagus is above the level of the stomach. So if there is reflux, gravity can return the contents back to the stomach. But if you look at the right side, you see that the esophagus is below the stomach. So whatever in the stomach can flow right back into the esophagus, causing reflux. So it's always a good idea to sleep on the left side so that the esophagus is above the stomach, and also to raise the head of the bed, because this promotes peristalsis and allows the gravity to help return gastric contents from the esophagus to the stomach. So again, sleeping on your left side and sleeping with the bed elevated is what you want to teach your patient to do. This is a picture of the Medcline pillow, which is something you might want to talk to your patients about also. It's the Medcline pillow, also called acid reflux pillow, but you can see that this pillow keeps the upper body and the head elevated. It can be purchased and used by the patient in their own bed. The patient, as it says here, sleeps comfortably in just the right position. Harmful acid stays in the stomach where it belongs. You can see that there's a place for the arm to go through. There's like a little slot there, and the arm just goes right through there, so the patient can get as comfortable as possible. You can also see the patient has a pillow under their head that's on top of the Medcline pillow. So it's just a good tool for the patient to have, and it's something that's good for us to recommend. They don't have to have it, but they won't know anything about this. So again, as a healthcare professional, this would be a good thing for us to talk to our patients about. So this does it for GERD, and now we are ready to go on to peptic ulcer disease. Peptic ulcer disease is a condition in which painful sores or ulcers develop in the lining of the stomach, or the first part of the small intestine, the duodenum. Normally, a thick layer of mucus protects the stomach lining from the effects of its digestive juices, but many things can reduce this protective layer, allowing stomach acid to damage the tissue. Pepsin plays a major role in causing mucosal damage or breaks in the lining of the stomach. The sores occur because the mucosa is unable to tolerate the digestive action between the gastric acid and the pepsin. This causes erosion of the wall or the mucosa. Erosion can also be caused by a decreased resistance at the protective mucosal barrier. So if we were in class, I would ask you, if peptic ulcers can lead to perforation and bleeding, what do nurses have to do? What would be very important for us to do? But since we're not in class and I'm doing this virtually, I'm going to answer that question for you now. And that is, nurses have to assess for signs and symptoms of bleeding. We also have to teach patients how to do this. We also have to closely monitor any drops in the H&H. There are 3 stages of peptic ulcer disease. Stage 1 is erosion. Here you see a destruction of the mucosal lining beginning. Stage 2 is the true ulcer. In this stage, if the erosion is not cared for, if it's not treated, you'll see a marked or scarred disruption of the stomach tissue in the stomach and in the duodenum. Stage 3 is excavation. It is the final and most serious stage of peptic ulcer disease. Here you have a bleeding ulcer known as an excavation, or hollowed out area that forms in the mucosal wall of the stomach, the pylorus, the duodenum, or the esophagus. This excavation appears as a partial or complete hole in the tissue, causing hemorrhage, and you'll see that on the diagram there. You can see how the blood is pooling there. So you can see that if a patient is suffering from that, how it's very likely that the H&H is going to drop, and that's why we have to monitor it really closely, because bleeding and hemorrhaging like this is a medical emergency. It can cause significant GI complications, and it can be life-threatening. Let's take a look now at some of the causes and risk factors of peptic ulcer disease. The 2 most common causes of peptic ulcer disease are Helicobacter pylori bacteria and the overuse of NSAIDs. Let me talk a little bit about the 2 of these things first. So I think it's safe to say that the most common cause is an infection of the stomach lining with Helicobacter pylori, often referred to as H. pylori. H. pylori is a type of bacteria. After H. pylori enters the body, it attacks the stomach lining, resulting in acid getting through the lining of the stomach, leading to peptic ulcer disease. It's unclear exactly how this bacteria spreads. Researchers believe it's mostly through unclean food, water, and eating utensils. People who carry H. pylori can also spread it through direct contact with saliva. Many people get this bacterial infection as a child, but it rarely develops into a peptic ulcer. In fact, most people don't see symptoms until they're older, if at all. Another common cause of peptic ulcer disease is the overuse of NSAIDs, such as aspirin, ibuprofen. People who use or rely on nonsteroidal anti-inflammatory drugs, including naproxen, are more likely to develop peptic ulcers. After H. pylori, I would say that NSAID use is the other major cause of peptic ulcers. NSAIDs can irritate and damage your stomach and intestinal lining. Acetaminophen, or Tylenol, is not an NSAID, so it's often recommended for people who can't take NSAIDs due to ulcers or other digestive conditions. Another cause of peptic ulcers can be the development of stress ulcers. So stress ulcers are acute mucosal ulcerations of the duodenal or gastric area occurring after physiological stressful events such as burn, shock, sepsis, people that are critically ill. They are clinically different than peptic ulcers. They are most common in patients on ventilators after trauma or surgery. They appear as shallow erosions of the stomach wall. 72 hours after a traumatic event, you can see multiple gastric erosions. As stressful events continue, the ulcers can spread. When the patient recovers, the lesions are reversed. Emotional stress is not the same as physiological stress. Emotional stress is no longer thought to be a real cause of ulcers, but people who are experiencing it often report increased pain of existing ulcers. Contrary to commonly held beliefs, ulcers aren't caused by stress or foods you eat. Most of the time, bacteria, as I said before, causes them. Doctors can treat the bacteria with antibiotics and other medications, which we'll talk about in a little bit. The appropriate treatment can heal an ulcer in a matter of weeks. Our second case study involves Mrs. Abbott. Mrs. Abbott is a 47-year-old teacher. She has made an appointment with her physician because over the last several months she has had increased episodes of burning epigastric pain near the midline in the epigastrium and in her back. Other concerns include the following: pain that occurs 2 hours after meals and is relieved after taking an antacid. Recently, she has had episodes of pain that wake her up at night. She explains that she has been taking ibuprofen for joint pain resulting from a car accident. She's been taking this for quite a while. Periodically, she has noticed that her stools seem darker and harder than usual. She said that she has experienced painful vomiting that contains blood. A recent blood test revealed a low hemoglobin and hematocrit. The most common symptom of an ulcer is burning pain in the stomach between the breastbone and the belly button, and this can mimic chest pain. So once again, careful assessment is really important because one of the first things that we might think about is chest pain, heart arrhythmias, heart attack. So we have to be really careful when we assess these patients and not come to automatic decisions that, this is what it must be. With peptic ulcer disease, patients develop painful sores in the lining of the stomach and the duodenum, like we said before. And those painful sores are obviously what's causing the burning pain in the stomach. Other common manifestations of peptic ulcer disease are pyrosis, a feeling that you're full even if the stomach is empty and you haven't eaten, nausea and vomiting, bloating, constipation or diarrhea, bleeding. Patients may be anemic, so of course we talked about how we're going to be checking their H&H. So make sure you know this and know the medical terminology. So signs and symptoms of peptic ulcer disease depend on ulcer location. Many patients, especially older patients, have few or no symptoms. Symptoms of gastric or duodenal ulcers are similar. The most common complaint is a burning pain in the stomach, like we talked about. There are some differences in the signs and symptoms of gastric and duodenal ulcers, and they're listed on the side and on the slide. So, take a look at that and be familiar with what the signs and symptoms of gastric ulcers are and what the signs and symptoms of duodenal ulcers are. And there's some real differences. With the gastric ulcer, you're going to most likely see a weight loss. With the duodenal ulcer, you're going to most likely see a weight gain. With a duodenal ulcer, the pain is going to typically awaken patients at night. That's not true for gastric ulcers. So, take a look at this and be familiar with them. Pain is the most common symptom of peptic ulcer disease. Never make assumptions about pain. Acute pain may be a sign of complications such as perforation or a sudden intense epigastric pain and rigid abdominal muscles. Or it may be totally unrelated to peptic ulcer disease. It could be related to pancreatitis or coronary heart disease or gallbladder disease. So again, assessment is extremely important. Because the epigastric pain can mimic myocardial infarction or an MI, oftentimes, like I said, an EKG is performed, and if a patient is hospitalized, they may be placed in a telemetry unit to monitor for any dysrhythmias, just to make absolutely sure, and so that any kind of cardiac problem can be ruled out. Some patients may present with anemia due to acute or chronic blood loss. If that is the case, an extremely important nursing intervention would be to monitor the patient for bleeding. So what are the things that we would pay close attention to? Vital signs, checking the stool guaiac. Are the stools black and tarry, or are they a normal kind of brown color? Vomitus, check for blood. Do we see coffee ground vomitus? That would be an indication that there's bleeding. And of course, like we said, we check the H&H because if there's a lot of bleeding, we're going to see a decrease in the hemoglobin and hematocrit. The nurse must complete a comprehensive evaluation of the pain, especially with an acute onset of pain. So you'd want to ask all those questions that we've taught you to ask when you're doing a really good pain assessment. Caring for Mrs. Abbott should begin with a complete and accurate assessment. A list of assessment data and nursing diagnoses or patient problems are listed on the slide here, but again, they're just a beginning, they're just examples. But it'll be important to do a pain assessment. It'll be important to get a good medical history, and everything that is listed here are important factors to look into. During the assessment, you want to include the following: vital signs. Is the patient tachycardic? Is there hypotension? Could this indicate anemia or a GI bleed? Complete a really accurate pain assessment. What relieves the pain? The patient states that the pain is relieved after eating but returns 1 to 2 hours after eating. So again, it's relieved after eating, but that doesn't last forever. A couple hours after eating, the pain returns. So you want to know what the characteristics of these different diseases are, because when you understand and know what those characteristics are, you're going to have a better idea of what to focus on when you do your assessments. What about vomiting? How often? If the patient vomits, how often do they vomit? What are the characteristics of the vomit? Is it bright red? Is there coffee ground vomitus? Is there undigested food in the vomit? What about the stools? Are they bloody? Are they tarry? Are they black? Are they hard? What about the patient's food intake? What about the use of NSAIDs? These are all questions you're going to want to ask your patient. Is there a family history of this kind of a problem? I do want to say here that you'll see on the slide that one of the diagnoses that I put up here is risk of deficient fluid volume. So I just want to say a few words about risk diagnosis. If you're asking me, using a risk diagnosis, absolutely okay. They are more than okay in my opinion. They help you identify potential problems that you can then address before they become an actual or more serious problem. So I actually like my students to, I'm not saying that every diagnosis should be a risk for diagnosis, but I think, you're using your critical thinking skills when you come up with risk for nursing diagnoses. A complete and accurate assessment can provide valuable information both in terms of diagnosing and identifying the best possible interventions. The information that you gain will also help the medical and nursing team know what to do and what to focus on in terms of lifestyle changes. The patient history and the physical exam are very important parts of the patient workup. When you're assisting with a physical exam, remember a few things. Remember to provide visual and audio privacy, in other words, complete privacy for the patient. Expose only the part of the body that's being examined. Maintain infection prevention precautions for sure. The physical exam should not be limited to only the presenting problem. Be sure that the general appearance of the patient and any nonverbal cues are considered, and that's something that you can do as a nurse. Some of these other things are going to be done by the physician. You'll probably be assisting the physician, but certainly when it comes to the general appearance of the patient and any nonverbal cues, that's something that you can definitely take note of. And of course, everyone needs to be kind, understanding, and use therapeutic communication. Before the diagnostic exams are done, it's important to perform this physical exam. It'll give you a lot of input in terms of what's going on with the patient, and it'll actually help lead the doctor and the nurse in the right direction. For this patient, the physical exam revealed epigastric tenderness, abdominal distension, both of which are objective data. Subjective data included a pain level of 8 using a pain scale of 0 to 10, 10 being the highest level of pain. With Mrs. Abbott, the physician expects the problem is a duodenal ulcer. With the duodenal ulcer, remember the pain gets better with eating, and the pain wakes the patient up at night. Another thing that you should certainly ask the patient is, has she noticed any recent weight gain? Based on Mrs. Abbott's risk factors and complaints and her physical exam, the physician suspects that her underlying problem is peptic ulcer disease, more specifically a duodenal ulcer. To confirm the diagnosis, the doctor will order specific diagnostic procedures that may include the following, and you can review this slide on your own, but I just want to talk about a few of these things. The upper GI endoscopy. In this test, you're looking for evidence of an ulcer in the intestinal lining. It's the preferred procedure for evaluating peptic ulcer disease. Although peptic ulcers can be diagnosed during an upper endoscopy, lab and radiological tests may help narrow the diagnosis. Some patients with peptic ulcer disease are anemic because of acute bleeding or a chronic blood loss. You can really lose a lot of blood if you're bleeding small amounts over a long period of time. So again, and Mrs. Abbott's stool was hard and tarry, which indicates that there probably was bleeding. So with her, you're going to have to be very careful in terms of monitoring the H&H. The upper GI endoscopy is the preferred procedure for evaluating peptic ulcer disease because of its sensitivity and specificity. It really tells you so much about what's going on with the patient in the GI tract. The doctor with this test is able to determine if H. pylori is present, and the doctor may also be able to see lesions not detected on X-ray. For this test, the patient is sedated. During the exam, the doctor threads a long, flexible tube with a tiny camera at the end, and it's kind of like what we talked about when we were talking about GERD. So this is threaded down the throat into the esophagus and then into the stomach and duodenum. This instrument allows the doctor to view any irregularities in the upper digestive tract and remove any tissue samples or a biopsy. Again, looking for H. pylori, or also you can rule out any kind of cancer when you're taking these samples or these biopsies. These samples are analyzed specifically right now for H. pylori because we know that H. pylori is a huge risk factor for peptic ulcer disease. The test is done to investigate symptoms that may be caused by other conditions such as gastric ulcers or gastritis that may be due to H. pylori. The test may be repeated after treatment depending on what's found at the first endoscopy or if symptoms persist after H. pylori treatment. During the second exam, again, biopsies can be performed to make sure that H. pylori has been eliminated. If a patient was previously diagnosed with and treated for H. pylori, the doctor will generally wait at least 4 weeks after completion of antibiotic treatment to perform any more tests. We need to allow the antibiotics to, to do their thing. Okay. So one other thing, this test isn't always recommended solely to diagnose an H. pylori infection because it's more invasive than a breath test or a stool test. But it may be used to perform detailed testing for doctors to determine exactly which antibiotic to prescribe to treat the H. pylori, especially if antibiotics fail, or to rule out any other digestive conditions like some kind of cancerous growth. Okay. So the test results come back. They confirm the presence of an ulcer. The upper GI indicates the presence of an ulcer. The H and H are low, indicating that there is bleeding. The occult blood test indicates that there is blood in the stool. The blood test came back positive for H. pylori. A biopsy of the mucosa confirmed that there were no cancerous lesions, so of course that's wonderful news. So now we're ready to move on to the next part of the nursing process, which is the plan. So based on the initial physical exam, the results of the diagnostic procedures, and the lab exams, Mrs. Abbott's doctor is ready to discuss what the plan of care will be. Though ulcers can sometimes heal on their own, patients do need to pay close attention to warning signs, because if treatment is needed and patients don't get that treatment or the appropriate treatment, ulcers can lead to serious health problems, including bleeding, hemorrhaging, perforation, which is a hole through the wall of the stomach. So, if you don't need treatment, that's one thing, but if you do, it's really important to get that appropriate treatment. If you have ulcers caused by H. pylori, patients will need treatment to kill that bacteria. And then to heal the stomach lining and keep the sores from coming back. It usually takes about 1 to 2 weeks of treatment for the patients to get better. Peptic ulcers treated with antibiotics to eliminate H. pylori have a lower reoccurrence rate than those not treated with antibiotics. So these patients with H. pylori will be treated with antibiotics. H. pylori infections are usually treated with at least 2 different antibiotics at once to help prevent the bacteria from developing a resistance to one particular antibiotic. The doctor will prescribe or recommend an acid suppressing drug also to help the stomach lining heal. For the last 2 decades, the recommended treatment for H. pylori eradication was a triple therapy. using proton pump inhibitors or ranitidine bismuth citrate combined with amoxicillin or metronidazole. But in November of 2019, the FDA approved a new drug called Talicia to treat H. pylori infections. This new medication has been shown to be safe and more effective than other antibiotics like Biaxin or Flagyl or Levaquin. So you'll probably see Talicia used more frequently if you're ever taking care of patients with peptic ulcer disease. Because patients tend to become symptom-free within a week, the nurse has to stress the importance of following the medication instructions so that healing can successfully be completed and the ulcer symptoms won't return. The patients may be on maintenance therapy for a year. However, not all patients require maintenance therapy. Most likely, the maintenance therapy is given to those patients with 2 to 3 recurrences per year of peptic ulcer disease, or if they've had complications such as bleeding or obstruction. So just make sure that you review this medication slide. Know that ulcers often get better with antibiotics, acid blocking medications, and not by using NSAIDs, of course. I also want to point out that there have been studies recently questioning whether long-term PPI use may have an association with stomach cancer. As more research needs to be carried out, the current advice is that PPIs should be taken at the lowest dose for the shortest length of time. You may find that patients are able to take PPIs just occasionally rather than daily. However, if the patient finds that other medications haven't helped and that symptoms are persisting, then currently the advice is to continue taking the PPI medication until advised otherwise by the doctor. So that's just, you won't be tested on that. I just wanted to give you some updated information. With the increased effectiveness of medications to treat peptic ulcer disease, surgical treatment is usually only required with non-healing and bleeding ulcers or intractable ulcers, those not healing after 12 to 16 weeks of medical treatment, or hemorrhage, perforation, or obstruction. Surgery can be done traditionally, and that is by an open abdominal approach requiring a long abdominal incision, or it can be done by a laparoscopic surgical procedure requiring just very small abdominal incisions. This is a minimally invasive procedure and has a much shorter recovery time than the traditional open approach. Now, the laparoscopic procedures are not always possible for many different reasons, and so the surgeon will make the decision whether to do an open abdominal approach or a laparoscopic procedure. When possible, they will always choose the laparoscopic procedure, just because the recovery time is so much quicker, the chances of infection are smaller, and it's just all around better for the patient. Recovering from a pyloroplasty is fairly quick. Most people can begin to gently move or walk around within 12 hours after surgery. Mrs. Abbott's ulcer is showing signs of healing, therefore surgery will not be necessary at this time for her. Complications associated with peptic ulcer disease include GI bleeding, perforation, which is a situation where the ulcer breaks through or perforates the wall of the first part of the small intestine, or the duodenum. GI contents then are released into the abdominal cavity, resulting in peritonitis. It's very important to explain possible complications to the patient and family members calmly and compassionately and with understanding. You don't want to scare the patient, but you do want them to be aware of what to watch for, what to watch out for, and what problems should be communicated to the physician immediately. The patient needs to know when to call the doctor and when to skip calling the doctor and go directly to the emergency room. With perforation, you can have intense epigastric pain, which may be referred to the shoulder, ulcers, you can have a tender abdomen, you can have rigid abdominal muscles, you can have hypoactive or absent bowel sounds. The patient needs to be told that should they feel some of these symptoms or these complications, and they're not sure, that they should just forget calling anybody and go directly to the emergency room. It's not worth sitting around trying to get somebody on the phone, waiting for someone to call you back. If you're experiencing any of these problems and you're just not sure what to do, just go directly to the emergency room. The worst thing that could happen is you get there and thankfully nothing is really wrong and you can go home. On the other hand, if you get there and something is very serious, then you can be treated immediately and perhaps save your life, or certainly, get you out of a situation that could have turned quite serious quickly. We're now ready to tackle the fourth piece of the nursing process, which is nursing implementations or nursing interventions. Some of the nursing implementations that we would use on patients with peptic ulcer disease I've listed here on this slide. Remember again that lifestyle changes, though very important, cannot happen overnight. In terms of dietary modification, the intent is to avoid oversecretion of acid and hypermotility in the GI tract. We also want to encourage the patient not to smoke. Smoking causes inflammation and increases stomach acid. It also slows healing. Not smoking may ease symptoms, for sure. Limiting alcohol is also important. Alcohol can irritate the stomach lining. This can worsen symptoms. Alcohol should be limited to 2 drinks a day for men and 1 drink a day for women. Alcohol and decaffeinated coffee also stimulate acid secretion just like regular coffee. Small frequent meals are not necessary as long as an antacid is taken if needed. 3 regular meals can help actually neutralize the acid. That, of course, is unlike GERD. In GERD, remember, we encourage patients to have small frequent meals. But when you're dealing with peptic ulcer disease, 3 regular meals a day is perfect. Patient education is the process of influencing patient behavior and producing the changes in knowledge, attitudes, and skills necessary to maintain or improve health. If we can do this, then hopefully we can get our patients to be compliant, and that's just going to enhance their healing and their recovery. So we want to do a few things, and there are many other things. I put down what I thought was pretty important. We want to explain that the administration, dosage, adverse effects of all prescribed medications, explain the importance of discussing with their doctor any over-the-counter meds before taking them. It's a really good idea to print out the medications that patients are going to be taking at home, how to take them, when to take them, try to get a schedule that's easy to follow. We want to explain that NSAIDs and medications containing aspirin, unless approved by their doctor, they should avoid. Consider alternatives such as acetaminophen. We want to help our patients identify lifestyle changes that should be made. Remember, that they can't be done overnight, but we will be supportive and help them make these changes. We want to make sure that they know the importance of drinking alcohol in moderation, if at all, and of course, we don't want them to smoke at all. We want to discuss the dietary modifications with our patients, explaining that spicy foods and beverages containing caffeine stimulate gastric acid secretions, which can make their peptic ulcer disease worse. We want to explain the importance of avoiding food within 2 hours of bedtime. Eating late increases the production of gastric acid, causing irritation to the stomach lining, which just can make the peptic ulcer disease worse. We want to explain the importance of monitoring and reporting any symptoms or changes in their health to their doctor, not to be afraid to call. Don't wait till things get worse. If they have questions, just call. Remember that it's not necessary to have small, frequent meals throughout the day. 3 regular meals can help neutralize the acid. The likelihood of recurrence decreases if the patient avoids smoking and coughing, like we talked about, and other caffeinated beverages, and if they avoid alcohol and NSAIDs. Over-the-counter meds may interfere with prescribed meds, which is why we need to make sure our patient discusses their medications that they're getting over the counter with their doctor. Of course, we'll have ongoing discussions with our patients about the medical diagnosis, about diagnostic testing, and their treatment plan. We want to be sure that the patient understands the treatment plan and is willing to adapt to it. We want to do this before the patient leaves the hospital. Or if you're working with this patient as an outpatient, then we want to make sure that we discuss all these things while they're in the office. And if it means they have to come back a couple of times to go over, so be it. Remember that discharge planning and patient education begins on the day of admission and never ends. We don't want to start educating our patient an hour before they're going to walk out of the hospital. They're not going to remember anything. It's going to be useless. So again, discharge planning, patient education starts the day the patient's admitted to the hospital. Okay, 2 down and 1 more to go. So now we're going to learn about cholelithiasis and cholecystitis. Okay, a couple of facts about cholecystitis. The incidence of gallstones and cholecystitis increases with age, and 2, gallstones are more common in women, and they're uncommon in children and young adults. In terms of this slide, I want to make sure that you review the medical terminology here. Cholelithiasis refers to stones or calculi in the gallbladder. Cholecystitis is acute or chronic inflammation of the gallbladder due to an obstruction of bile flow. And 3, acalculous cholecystitis is associated with biliary stasis, which we're going to talk about a little bit later. Here there is a slowing or a stopping of the flow of bile, either from decreased contractility of the gallbladder or spasms in the sphincter of Oddi. And the other thing about this slide is just to take a look at the diagram and understand where the gallbladder is, where the cystic duct is, and where the common bile duct is. Let's do a quick review of the pathophysiology of the gallbladder. The gallbladder is a pear-shaped organ located under the liver. It stores bile, which is a fluid made by the liver to digest fat. Bile is a thick green liquid that helps your body digest foods. As the stomach and intestines digest food, the gallbladder releases bile through a thin duct, which is the cystic duct, and the cystic duct leads to the common bile duct, and you can see this on the diagram. Remember your anatomy. The cystic duct connects the gallbladder to the common bile duct. The common bile duct connects the gallbladder and the liver to the small intestine. During this process, fats are broken down and absorbed. The gallbladder is most likely to cause a problem if something blocks the flow of the bile through the bile duct. The blockage typically is a gallstone. Gallstones form when substances in the bile begin to harden. Gallstone attacks typically occur after eating. Gallstones can be small, hard masses that form in the gallbladder, or they can be larger. They're made up of cholesterol, calcium salts, and bile pigments. About 10 to 15% of the population has gallstones, and this incidence varies among ethnic groups. Gallstones vary in size. Like I said, they can be very small, they can be large, they can be as small as a pea or as large as a softball. Patients can have multiple stones or they can have a single stone. The risk of developing pigmented stones increases in patients with cirrhosis and infections of the biliary tract. Gallbladder disease with stones is the most common disorder of the biliary system. Most people with gallstones have no pain and are unaware of the presence of stones. And so in terms of what's on the slide, just review this. Understand what the cholesterol stones are, what pigmented stones are. The cholesterol stones are the most common stones that people will have. Okay. Risk factors of cholecystitis are listed here on the slide. Some people develop gallstones without having any of these risk factors. Regarding estrogen, estrogen increases biliary cholesterol secretion, causing cholesterol supersaturation of bile. So therefore, hormone replacement therapy in postmenopausal women and oral contraceptives have also been described to be associated with an increased risk for gallstone disease. The incidence of gallstones have been thought to be more common in females over 40 as they were reaching premenopause. Women who were fertile, meaning that they had one or more children, also are thought to be at higher risk due to higher estrogen levels and the association of gallstones with pregnancy. A 2013 study found that family history is one of the strongest risk factors for gallstones. In terms of body size or obesity, it's thought that weight cycling or yo-yo dieting may increase the risk of gallstones. Advancing age, the incidence of stone formation increases with age as a result of increased hepatic secretion of cholesterol along with decreased bile acid synthesis. And this is explained well in your book on page 1431 if you want to just look over that. It's just interesting to read that. Gallstones can't be prevented. However, you can definitely decrease your risk factors by following healthy lifestyle tips. It's important to maintain a healthy weight through exercise and a balanced diet. So again, that would be something we'd want to teach our patients. Talking to your physician about weight loss and cholesterol management is also a pretty big part of preventing gallstones. We're ready now for our final case study, which involves Mrs. Brady. Mrs. Brady is a 40-year-old female and mother of 4 children. She's being seen in the outpatient clinic with the following complaints. She has a fever of 99.9. She's complaining of pain and tenderness in the right upper quadrant that radiates to the back. Her pain is a 7 to 8 out of 10. She has an increased respiratory rate. She's feeling tired and anxious. She's complaining of pain after eating certain foods, along with an 8-pound weight loss over the last 2 weeks. She describes her abdomen as feeling larger than usual, and we use the word bloated to describe that feeling. And she describes her abdomen as being tight with episodes of nausea and vomiting. She also describes her stool as being clay-colored. So let's talk a little bit about that. The liver releases bile salts into the stool, which typically cause the stool to be brown in color. When a patient describes stool as being clay-colored, then it indicates that there is a problem with the gallbladder, the liver, the pancreas, or the bile ducts. And we'll talk more about this during the next slide. If there is a liver infection causing a reduction in bile production, or if the flow of bile out of the liver is blocked, the stool will have a clay-colored appearance, right? Because the bile salts that are released into the stool, which typically cause the stool to be brown, that's not happening. So that means that the stool will have a clay-colored appearance. Bile can become trapped in the gallbladder. Again, we're talking about gallstones here, and typically if bile becomes trapped in the gallbladder, it's because of gallstones. The gallstone blocks the cystic duct. That's, remember, the tube through which the bile travels in and out of the gallbladder. So if that duct is blocked, we're going to have clay-colored stools because, again, the bile salts aren't getting through. So clay-colored stool is a result of a decrease or an absence of bile. So that's what I want you to remember. That's important. A patient with gallbladder disease as a result of gallstones may develop two types of symptoms: those due to disease of the gallbladder itself and those due to obstruction of the bile passage by a gallstone or gallstones. The gallbladder is a storage compartment for bile, which is produced by the liver. The gallbladder emits bile into the small intestines via the cystic duct. The entire process is meant to break down fatty foods. One of the most common symptoms of gallstones is pain that begins in the upper right portion of the stomach. That pain typically radiates outwards, gradually moving to the center of the stomach or to the upper back, but it typically again begins in the upper right portion of the stomach. Gallstone pain can occur at any time, but it's most common after eating fatty or greasy foods. This makes sense, right? Because we said that the gallbladder works to promote the breakdown of fatty foods. Gallstone attacks usually last 15 minutes, but many patients report lingering pain for quite a while afterwards. So though it's typical to last for 15 minutes, in reality, I think you're going to see patients saying that their pain lasts longer than that. Mrs. Brady is presenting with many of the clinical manifestations of cholecystitis. She's complaining of pain and tenderness and rigidity in the right upper quadrant of the abdomen. She's complaining of mild GI symptoms. She's complaining of epigastric pain, which may be described as colicky, intermittent, and radiating to the back. She's complaining of nausea and vomiting. She's complaining of pain and indigestion, but she came in really complaining of pain after eating fatty or fried foods, and she's complaining of clay-colored stools. She also has lost 8 pounds in just 2 weeks, and she has 4 children. So let's take a closer look also at some of the other clinical manifestations that patients can have. Again, the clay-colored stools. Remember that the liver releases bile salts into the stool, giving it a normal brown color. Clay-colored stools occur when there is a liver infection that reduces bile production, or if the flow of bile out of the liver is blocked by a gallstone and the bile salts don't get into the stool. Yellow skin, we refer to that as jaundice, often occurs with clay-colored stools, and this may be due to the buildup of biochemicals in the body that aren't getting out where they should go. Jaundice may occur. This is a result of the bile which is no longer carried to the duodenum. Instead, it's absorbed by the blood, which in turn gives the skin and the mucous membranes a yellow color. This may cause significant itching of the skin, and we refer to that as pruritus. The kidneys may cause the urine to become dark in color due to the excretion of the bile pigments. So don't confuse this with an increase in specific gravity related to dehydration. Again, it's because it's due to the excretion of the bile pigments through the kidneys now. The stool no longer is colored with the bile pigments. It'll be gray in color, but the urine could be dark in color. Then there's Murphy's sign. This is used during an abdominal examination when you expect that there may be a problem with the gallbladder. It's performed by asking the patient to breathe out while gently placing the hand on the right side near the approximate location of the gallbladder. The patient is asked to take a breath in. Normally, during inspiration, the abdominal contents are pushed downward as the diaphragm moves down and the lungs expand. If the patient stops breathing in, because the gallbladder is tender, and in moving downward comes in contact with the examiner's fingers, the patient will begin to wince, and we will see that the patient's in pain. This test then is considered positive. In order for the test to be truly considered positive, the same maneuver must not elicit pain when it's performed on the left side. So what you'll see is the doctor performing this test on both sides. And when he does it on the left side, there should be no problem. Okay, so that's kind of it for the clinical manifestations. And again, you see Mrs. Brady had several of them. As you saw on the previous slide, biliary colic is a clinical manifestation of cholecystitis. Biliary colic is abdominal pain caused by a temporary blockage in the ducts leading out of the gallbladder. People who have gallstones may, but not always, but they may have biliary colic. Biliary colic is also known as a gallstone attack or a gallbladder attack. So let's review. The cystic duct becomes obstructed by a stone. The gallbladder becomes distended, inflamed, and infected, resulting in acute cholecystitis. Biliary colic is caused by the contraction of the gallbladder, which cannot release bile due to the obstruction by the stone. The pain is severe and may require analgesics. If the gallstone is dislodged, the obstruction clears, the gallbladder drains, and the inflammatory process begins to subside. If the gallstone continues to obstruct the duct, then we can have abscess, fever, necrosis, and perforation and peritonitis all may result. The pain usually begins suddenly. Once it begins, it's usually a moderate kind of steady pain. Most commonly, an episode of biliary colic happens within a couple of hours after a person has eaten a meal, often a large meal with a lot of fat, which we have discussed. Biliary colic doesn't improve after having a bowel movement. Typically, the pain gradually goes away over 1 to 5 hours. It differs with different patients and the circumstances, but it begins to go away as the gallstone moves out of the duct. Most of the time, people with biliary colic don't have additional symptoms, though they sometimes do complain of nausea and vomiting. If the pain persists, or if the patient has a fever, they might not be experiencing biliary colic, they may be experiencing complications from the gallstones. For example, some people with gallstones get cholecystitis, which is inflammation of the gallbladder. They also can get pancreatitis, which is inflammation of the pancreas, or they get cholangitis, which is inflammation of the biliary tract. Gallstones are by far the most common cause of a block in the biliary ducts causing biliary colic. And again, all of this makes you realize that an accurate and complete assessment is incredibly important for this problem, or for any GI problem, for actually any problem, right? We always have to make sure that we do complete and accurate assessments, and we have to make sure that we report and document our findings accurately. A doctor will normally ask if a patient has a history of cholecystitis because it often recurs. A physical examination will reveal how tender the gallbladder is. Always provide the patient with education regarding the purpose of the test or the examination, what to expect during the test or the examination, and any side effects that may occur when the test is over. And obviously, we don't want to forget that when we're doing a physical exam, that we provide privacy. Based on Mrs. Brady's risk factors, her complaints and physical exam, the doctor suspects that her underlying problem is cholecystitis. To confirm this diagnosis, the doctor will order specific diagnostic procedures that can include the following. Now let's look at some of the more definitive exams for gallbladder disease. The ultrasound is the procedure of choice. It's quick, it's accurate, there's no exposure to ionizing radiation, and the results are most accurate if the patient is NPO after midnight. Abdominal x-rays may also be done. They can exclude other possible problems and help pinpoint the problems associated with the gallbladder. So other tests would include CBC, liver enzymes, the CT scan, the HIDA scan, and the cholangiogram, and you can review all of these on the slide. But these would be the tests that we would use for cholecystitis. But again, the procedure of choice would be an ultrasound, and of course abdominal x-rays would be also done for sure. The test results come back. They confirm the diagnosis of acute cholecystitis. And now, once again, following the nursing process, it's time to look at a treatment plan. The treatment plan will include a laparoscopic cholecystectomy along with medical management. The goals of the treatment will be to relieve pain, remove the gallbladder stones, and avoid any complications. Taking the gallbladder out is usually the best way to treat gallbladder problems. You might get some relief from changing your diet. For example, eating less fat can help, but gallstones rarely go away on their own. Treatments that break up gallstones or make them melt away or dissolve do not usually work well. That being said, let's take a look at the major objectives of medical management. Those objectives are to reduce acute episodes of gallbladder pain by providing supportive and dietary management and hopefully remove the cause of cholecystitis with medication or surgical intervention. Most of the non-surgical approaches like UDCA will provide only temporary solutions. They eliminate the risks associated with surgery. However, the patient will usually continue to have problems associated with gallbladder stones. When a stone blocks the bile duct or the cystic duct, the bile will build up, causing irritation and pressure in the gallbladder. This can lead to infection and/or inflammation and pain, requiring possible antibiotics or pain medication. Accurate and complete assessment is really important. Morphine is contraindicated because it can cause the sphincter of Oddi to spasm, resulting in increased pain. Remember that the sphincter of Oddi, when not working properly, can cause biliary stasis, which also can lead to infection. Demerol is an option. If patients taking the oral natural bile acid drugs stop taking them in the middle of the course, the stones may reappear. Because of the lengthy treatment of a course of medication, many patients begin to be non-compliant. Patient education along with support is very important. Medications that patients take by mouth may help dissolve gallstones, but it may take months or years of treatment to dissolve the gallstones in this way. Gallstones will likely form again, like I said, if treatment is stopped. UDCA is used for patients who refuse surgery or when surgery is not indicated. However, the success rate is low and the recurrent rate with UDCA is high. There is much better luck with laparoscopic or open cholecystectomy. Conservative treatments such as dietary modifications usually can't stop gallstones from reoccurring. In most cases, a cholecystectomy will prevent gallstones from coming back. So now let's take a look at surgical management, which is really the treatment of choice. And in this case, we're talking about laparoscopic cholecystectomy. So I mentioned the T-tube on the previous slide. So let's just talk about this for a second. The T-tube provides a way to monitor bile drainage. This tube is inserted with the intention of preventing the buildup of bile in the common bile duct due to temporary swelling, which is common after any cut in any part of the body. The buildup of bile along with the swelling can potentially prevent the healing of the bile duct, resulting in a leakage of bile from the common bile duct into the abdominal cavity. Uncontrolled bile leak can be potentially life-threatening if this is not recognized and treated quickly. In addition to acting as a drain, which drains the bile from the common bile duct to the exterior, dye can be injected into the tube, and an X-ray can be used then to demonstrate any residual stones. Once the absence of residual stones is confirmed, the T-tube can be removed. However, surgeons are concerned about the tiny hole which the T-tube leaves when it is removed. This tiny hole in the common bile duct normally heals without a problem, but in some patients, bile can leak through this hole and cause the very problem that the T-tube was meant to prevent. Remember, it was meant to prevent buildup of bile in the common bile duct. So, the use of a T-tube after a laparoscopic procedure remains a controversial issue. But if a T-tube is placed, the drain may need to stay in place for up to 6 weeks. This allows a muscular tract to form around the drainage, and this hopefully will prevent bile leakage into the belly when the tube is removed. The drain site must stay clean and dry. It must be covered if the patient showers, and this is to protect the patient from infection, and it must be protected from accidentally getting pulled out also. The purpose of the T-tube again is to drain the common bile duct and monitor the drainage for for color, and for the presence of any stones. So if you look on the slide here, the patient's going to be sent home with this tube. They're not going to be staying in the hospital for the whole amount of time the tube has to stay in place. So they need to be educated in terms of what to look for. So the patient should expect 300 to 500 cc's of thick blood-tinged bright yellow to dark green bile drainage during the first 24 hours after surgery. After about 4 days, the amount of drainage will be less than 200 cc's a day. The patient needs to be informed that he or she needs to report any drainage greater than 500 cc's per day. In the end, we must be sure that all stones have been removed. So to confirm the absence of all stones, an X-ray will be done prior to removing the T-tube, just to see what the situation is with stones. If the patient sees that the drainage is clay-colored, what would this indicate? So hopefully you realize that it could indicate a blockage, right, in the common bile duct. Okay. Now it's time to take a look at an important piece of the nursing process, and that is nursing interventions. This slide lists some of the important nursing interventions that should be implemented for Mrs. Brady and patients like her. And it lists some of the important aspects of patient education that should be shared with Mrs. Brady also. So it's a really good idea for you to review this slide. Some of the nursing interventions that I want to point out obviously are to assess the vital signs, place the patient in a Fowler's position. This promotes the bile drainage by gravity. Administer analgesics as ordered to alleviate pain. Remember, we need to avoid morphine, and most likely if the patient needs narcotic, they'll probably use Demerol. Administer antiemetics as ordered. We want to make sure that we maintain skin integrity. So again, you can review all of these nursing interventions, and there's certainly many, many others. Antiemetics decrease symptoms of nausea and vomiting, which may occur for a prolonged period of time due to abdominal pain and obstruction. So again, it'll be important to continually assess the patient's complaints of nausea and vomiting. The T-tube There are certain things that we're going to definitely need to do. We have to assess the drainage. We need to know about the color, the amount, like we talked about. Be sure there is no kinking of the tube. We don't want the tube to get pulled out, so we should most likely, it's a good idea to pin the tube to the gown. It's best to have small, frequent meals. Unlike ulcers, where 3 regular meals were advised, here small, frequent meals, again, would be a good idea. We want to neutralize stomach acids. That's going to be our goal. The bile breaks down fats, so a diet high in fats, fried and fatty foods, requires activation of bile for breakdown and increases pain. So remember that without bile, we're unable to break down the fat. So again, fried and fatty foods, not a good idea. When discharged, there is usually no special dietary instructions other than to maintain a healthy diet and to avoid excessive fats. Fat restrictions may be discontinued after 4 to 6 weeks. A positive outcome of gallbladder removal is that the patient can resume a normal diet once healing has been completed. However, for many reasons, avoiding excessive fats is a good thing to do. We can talk to our patients about that. We also definitely want to encourage follow-up care with the doctor, so we want to talk to our patient about that. One thing to include in patient education is, when should the patient call the doctor? Call your doctor. We want to tell our patients to call their doctor right away if they have any of the following: pain that becomes worse, especially in the upper right portion of the abdomen, excessive nausea or vomiting, fever above 100.4 degrees Fahrenheit or chills, swelling or fluid leaking around the tube, any new redness or warmth around the incision, or new fluid draining from the incision, an incision that does not heal after 3 to 5 days, stitches that become infected, red or tender, or become loose, a foul smell from the incision site which could indicate infection, drainage that changes color from light pink to dark red, a T-tube that stops draining, because then we'd be worried that there is some kind of blockage. And of course, we would certainly call the doctor right away if the T-tube falls out. So just review this slide. There's some important information here. You definitely want to know all the different things that we need to teach our patient, and we want to know what the interventions would be. And again, you want to know the rationale behind the nursing interventions. So we want to reduce Mrs. Brady's risks, right? So following these suggestions can help reduce the risk of developing gallstones and cholecystitis, and also they're just things that are important for us to include in patient education, and they're helpful tips for the prevention of gallstones. So avoid saturated fats, keep a regular breakfast, lunch, and dinner time, schedule and try not to skip meals, exercise 5 days a week for at least 30 minutes, maintain a healthy weight. Obesity will increase the risk of gallstones. Avoid rapid weight loss, as this increases the risk of developing gallstones. A healthy weight loss is generally around 1 to 2 pounds per week. So again, sharing these little tidbits to our patients will be helpful. Let me just say a few words about discharge planning and home health care, both of which are really important when we're taking care of any patient. Discharge planning, like we've always said, is huge. A large part of discharge planning is patient education, and we know that discharge planning should always begin on the day of admission. Home health care professionals can ensure that the right medications are being taken at the right times to control health conditions and to prevent harmful drug interactions. The goals of home health care services are to promote the patient's optimal level of well-being and to assist the patient to remain at home without complications. The most important part of home health care is to provide professional nursing care that meets the patient's individual needs. In consultation with the doctor, a registered nurse will set up a plan of care. Nursing care may include wound dressing, administering medications, and monitoring the general health of the patient, and of course, pain control. The professional caregiver provides the patient with customized care that specifically satisfies the needs of the patient. Home health care can greatly decrease the anxiety often present when patients return home from a hospitalization and suddenly are faced with continuing their recovery without the presence of professional health care providers. So if we feel that our patients need home health care, that's something that we can set up before the patient is discharged. So back to the art of caring, which we talked about at the beginning of this lecture. The art of caring. This should be a significant part of everyone's philosophy of nursing. Be compassionate, caring, understanding. Always try to listen to your patients. Watch and appropriately respond to your patients. Carefully observe their facial expressions. Therapeutic communication. Never forget the importance of using therapeutic communication when caring for patients and when working with the healthcare team. All of this will make a huge difference 100% of the time. Okay, now let's try some practice questions. Question number 1. The nurse is caring for a patient diagnosed with peptic ulcer disease. What findings will the nurse expect to see when doing an assessment? Select all that apply. So what do you think? Black tarry stools, abdominal pain, and tachycardia. Abdominal pain and black tarry stools are expected with peptic ulcer disease. As blood from the GI tract passes through the intestines, bacterial action causes it to become black and tarry. Tachycardia is an indicator of hidden bleeding. This would be an emergency and the doctor should be notified. Question 2. A patient has been admitted to the hospital with GERD. When assessing the patient, you identify the following risk factors that could be contributing to the diagnosis. Okay, take a few minutes. Okay. Patient states that he smokes. Patient is 5'4" tall and weighs 190 pounds. The patient has diabetes. The patient states that his favorite meal includes French fries. Okay, so these would all be risk factors that could contribute to the diagnosis of GERD. Question number 3. The nurse is reinforcing instructions to a patient being discharged with a T-tube. What information will be important to share with the patient? Select all that apply. I'm going to give you a few minutes. Okay. The T-tube is inserted to monitor the bile drainage, yes. Contact the PCP if the drainage becomes clay-colored, yes. Explain that for now it is best to follow a low-fat diet, yes. Remember that the T-tube drainage should not exceed 500 cc's in 24 hours for that first 24 hours. Antiemetics can be taken as directed. Spasms may cause pain, so pain medication is also allowed as directed. But again, remember, morphine is not used because it promotes spasms of the sphinx duravoti. Okay. Question number 4. A patient is brought to the emergency room with suspected cholecystitis. Which findings are characteristic of this diagnosis? Okay. Epigastric pain radiating to the back, indigestion after eating fatty meals, clay-colored stool, and pruritus. Remember, pruritus is the medical term that we use for itching. Question number 5. A patient is admitted to the hospital for the evaluation of epigastric pain. The patient states that the pain is relieved by eating. The patient reports awaking in the middle of the night with a gnawing pain in the stomach. Based on this presentation, the patient appears to have what type of ulcer? A duodenal ulcer. Remember, the key words here: relieved by eating, waking in the middle of the night, and epigastric pain. And our last question is, which of the following instructions should the nurse include in the teaching plan for a patient who is experiencing GERD? Do not lie down for 2 hours after eating. Okay, this has been a long couple hours. I hope that this was helpful. If you have any questions, please call me. We can Zoom together, or I can answer your questions through emails, but please don't hesitate to ask any questions. Good luck on your real exam that's coming up, and please, please, please enjoy your weekend.